Hi everybody, welcome to Dr Manny's YouTube Learn Shops. This is Pharmacology for Nurses Part 6, where we'll be reviewing analgesia, painkillers, and sedatives, hypnotic agents. Now the learning objectives for this session are to look at the related central nervous system physiology, pain-related factors, selected sedatives and selected analgesia, and then at the end of the Learn Shop, see what you have remembered. The central nervous system that we're concerned about today deal with the spinothalamic pathways. And it's these pathways, the ascending and the descending tracts, that transmit pain, along with other things such as temperature, but it's pain which we're interested in today. We have an anterior spinothalamic tract. We have a lateral spinothalamic tract. And these two are vitally important when we look at pain transmission. Where do we as human beings identify pain? Well, pain in the brain is identified in the cerebral cortex and in the limbic system. The somosensory area of the cortex and the limbic system receive transmission via the spinothalamic tracts to make us aware that we have pain. The main function of the spinothalamic tract then is to transmit pain via the lateral pathway so that we are aware that we have pain. And this is made aware to us in the cerebral cortex, because this is the sensing area for pain that's transmitted. Now, our natural painkillers are endorphins. And our natural or biological painkillers are released when the brain anticipates or receives or becomes aware that there's pain. Once the signal is transmitted and it's received, endorphins are released. And as a consequence of that, pain isn't quite as severe as it would be without the endorphins. Pain can be in any area in the body. Now, what are some of the pain assessment guides or scores that we can use to assess pain? Well, the two that I've chosen here are WILDA, which requires verbal communication, or FLAC, which is essentially non-verbal communication and seen as physical assessment. When we look at WILDA, we're talking about words. What's your pain like? The intensity, how bad is it? Location, where is it? Duration, how long has it been there? What aggravates it? What makes it better? All this information can be given verbally. However, sometimes you're not able to communicate verbally. If you're a neonate, if you're an infant, if you're a child, if you're an adult who's had a stroke, you're unresponsive. So face can tell you lots of things. A grimace, legs, moving or not moving. What activity are you doing? Are you restless? Are you agitated? Or are you really quiet? Are you crying? Are you consolable? And as a consequence of that, you get a score. We can also use the numerical for verbal communication, stating that, Madam, Sir, if you can communicate and understand, could you give this pain that you're having a rating from 0 to 10? 0 being no pain, 10 being the worst pain that you've ever experienced. So when we look at analgesia, or medications that alleviate pain, painkillers, we can put them into three categories: mild agonists, moderate agonists, or strong agonists. I've chosen acetaminophen as a mild agonist, acetaminophen and codeine phosphate. Moderate, tramadol hydrochloride, and tramadol hydrochloride and acetaminophen. Strong agonists, morphine sulfate, fentanyl citrate, and merperidine. But there are many, many others. Acetamin essentially is paracetamol. It's a non-narcotic analgesia, and it inhibits synthesis of prostaglandins in the central nervous system. Peripherally, it blocks pain impulses that are generated, and it has an additional antipyretic effect, which really isn't known theoretically as to why and where. The dosage is typically 250 to 1,000 milligrams, maximum 4 grams per day, and in pediatrics 10 to 15 milligrams per kg per dose 4 hourly. The indications are for mild to moderate pain or if you have a fever. The adverse effect could be, in overdose proportions, hepatic toxicity. Acetamin and codeine phosphate. Similar to acetaminophen, but codeine binds to opiate receptors in the central nervous system, so it gives you better, stronger analgesic effects. And again, it's for mild to moderate pain. However, the codeine could cause dependence, sedation, and the acetaminophen, hepatic toxicity in overdose. Then you've got tramadol hydrochloride. This is a non-opiate, and the exact action isn't really known. But it binds to mu opiate receptors, inhibits uptake of norepinephrine, therefore serotonin, and both inhibit ascending pain pathways, which alters your perception of the pain. It's also for moderate to severe pain, but the major adverse effects are vertigo, nausea, headache, and sedation. Tramadol hydrochloride with acetaminophen inhibit both ascending pain pathways, which alter your perception. Indications are for now a little bit stronger pain, moderate acute pain, and it's quite effective. Adverse effects include, again, vertigo, nausea, headache, and sedation. The dose typically is for tramadol 37.5 milligrams and acetaminophen 325 milligrams. When we look at stronger painkillers, we're looking at morphine sulfate. And morphine sulfate, it's the prototype for opiate analgesia, and it binds to the opiate receptors in the central nervous system, which inhibits the ascending pain pathways and alters your perception. This is for severe chronic pain and can be used during a general anesthetic. The major adverse effects are nausea, vomiting, bradypnea, and hypotension. Fentanyl citrate. This also binds to the central nervous system opiate receptors, but it's about 5 to 10 times more effective in much lower doses compared to morphine, which therefore means if you're giving a lower dose, there's less likelihood of adverse effects. And the indications are for severe pain in conjunction with sedation and anesthesia, but the adverse effects include bradycardia, respiratory depression, and hypotension. Adult doses are typically 50 to 100 micrograms per dose, pediatric 1 to 2 micrograms per kilogram per dose, and an IV infusion around about 1 to 3 micrograms per kilogram per hour in both populations. When we look at merperidine, demerol, sometimes referred to as pethidine hydrochloride, It inhibits the ascending pain pathways, but it has 1/10 the potency of morphine, therefore a lot less potent than fentanyl. This is for severe chronic pain and anesthesia. Adverse effects include constipation, nausea and vomiting, polydipsia, and dizziness. The opioid antidote is called Naloxone, Narcan, and its action is essentially to competitively block or combine with opiate receptors, reversing the action of narcotics. The indications are to reverse the medication maybe coming out of an operation, anesthetic, reversal of narcotic depression, respiratory depression, or if there's a narcotic overdose, such as heroin. The major adverse effects are nausea, vomiting, ventricular tachycardia, ventricular fibrillation, and hyper or hypotension. The dose is typically 0.1 to 0.2 milligrams, and it's given 3 to 5 minutely until you get the desired response. They wake up. When we look at other analgesia, we can also look at non-steroidal anti-inflammatory drugs, such as acetylsalicylic acid, aspirin. And it's a wonderful drug, really. The analgesic effect, however, is not known. It has an antipyretic effect in the hypothalamus, and it has an anti-inflammatory effect by inhibiting prostaglandins. It does many other things as well. However, the typical dose for analgesia is 81 to 1,000 milligrams 4 hourly. If it's a pediatric or an adolescent, it has to be ordered by a physician, because aspirin can cause certain syndromes in pediatrics which could affect their renal function. The indications are for mild pain, myalgias, arthralgias, dysmenorrhea, headache, juvenile, mature arthritis, and cardiovascular disease. Major adverse effects include hemorrhage, thrombocytopenia, dyspepsia, nausea, epigastric discomfort. It's an acidic medication. It can cause ulcers in your gastrointestinal system. Then you've got Naproxen, and this medication inhibits prostaglandin synthesis by inhibiting cyclooxygenase enzyme. And the indications are for mild or moderate pain, especially osteo and rheumatoid arthritis. Other forms of tendinitis, bursitis, even gout, or primary dysmenorrhea. Major adverse effects include tinnitus, headaches, constipation, and dyspepsia. But it's a very good analgesia. Sodium naproxen. Then you've got one of my favourites for pain, diclofenac sodium, Voltaren. And this medication inhibits prostaglandin synthesis by inhibiting cyclooxygenase enzyme. The adult dose is typically 12.5 to 50 milligrams with a maximum of 150 milligrams every day. Be cautious because it can cause stomach GI ulcers. The indications are for mild or moderate pain, osteoarthritis and rheumatoid arthritis, very good, primary dysmenorrhea, but the major adverse effects are fluid retention, gastric and intestinal ulcers such as a peptic ulcer, and diarrhea. When we look at sedation assessment, how do we assess that? And I've chosen this scale called the Ramsey scale. And essentially, it looks at 6 points for the one that I'm going to show you. There are other variations. So, point 1, or level of activity, patient is anxious and agitated or restless, which we don't want. Patient is cooperative, orientated and tranquil, We sort of do, yeah. However, the one we really want is the patient responding only to verbal commands when they're essentially asleep. Or the patient with brisk response to a light glabella tap or a loud auditory stimulus. We don't want a patient with sluggish response to light glabella tap or a loud stimulus, which means they're becoming very sedated. And they could move on to this one where the patient has no response to a light glabella tap or loud auditory stimulus. Where do we want the Ramsay scale score? We want it here. Patient responding only to verbal commands or to a brisk response to a light glabella tap or a loud auditory stimulus. Anything above may mean that they're not really sedated, and anything below means that they could be over-sedated. The Ramsay Scale Sedation Assessment Score. So when we look at sedatives, we're looking at benzodiazepines. They're both hypnotics and anxiolytics. The three that we're going to look at today are midazolam, diazepam, and lorazepam. Midazolam hydrochloride. This binds with the benzodiazepine receptors on the GABA neuron in the brain, decreasing sensory excitability. The indications are primarily used for critical care patients when they're being ventilated mechanically, or procedural sedation, which we used to call conscious sedation, light anesthesia. Major adverse effects could be hypoventilation, bradypnea, apnea, and hypotension. The doses depend on your organisational policy, but they can be given intravenously, they can be given orally, they can be given intranasally. Then you've got diazepam. Diazepam or Valium binds with receptors on the GABA neuron in the central nervous system as well, decreasing sensory excitability, and it's also a very good anticonvulsant. It is indicated for anxiety disorders and seizures or muscle spasm. It's used for procedural sedation, conscious sedation, and anesthesia. Adverse effects include respiratory depression, hypotension, possibly confusion. And lorazepam ativan also binds with the GABA neuron in the central nervous system, and it's a very effective anticonvulsant. It's used for anxiety disorders as well as seizures and procedural conscious sedation. Adverse effects include respiratory depression, hypotension, and confusion. It also has an antidote. So the benzodiazepines have an antidote called flumazenil or an exate. And the action of this medication is that it competitively combines with the central nervous system GABA receptors, blocking or reversing the action of the benzodiazepines. What's it indicated for? Reversal of benzodiazepine depression, which could occur during a moderate sedation, procedural sedation, conscious sedation procedure, respiratory depression, or overdose. Major adverse effects include nausea, vomiting, tremors, palpitations, and hot flushes. The important thing to remember is that if there's no response after 1 milligram, question the diagnosis. Something else may have happened. They could have had a stroke. They could have had a heart attack. They could have arrested. So, if no response after 1 milligram, question the diagnosis. And the same actually would apply with naloxone for the opiate antidotes. So let's review. Can you name 3 pain assessment tools? three pain assessment tools are Wilder for verbal communication, the numerical scale, which measures the intensity of Wilder, and FLAC, which is nonverbal communication. Can you name 2 mild analgesia medications? 2 mild analgesia medications are acetaminophen, paracetamol, acetaminophen and codeine phosphate, Vopac. What about 2 moderate analgesia medications? Tramadol hydrochloride, hydrochloride and acetaminophen. What about, can you name 3 strong analgesic medications? This would be fentanyl citrate or subliminase, morphine sulfate, MS-LON, Merperidine, demerol, pethidine. What about non-steroid anti-inflammatory drugs? Can you name 3? Aspirin, Naproxen, and I speak from experience, very good, Voltaren or diclofenac. What about the benzodiazepam medication? Can you name 3? And there are many, many more. You've got midazolam hydrochloride, Versed or Dormicum, lorazepam, ativan, diazepam, Valium. What about the narcotic antagonist? Correct, Naloxone, Narcan. What about the benzodiazepine antagonist? Flumazenil, Anexate. Correct. What about the sedation scale assessment tool? Can you remember what it is? It's the Ramsey scale, which in this case have got 6 levels. You want between 3 and 4 points. So look, thanks. That's the end of this Learn Shot. If it's been of any benefit to you, please recommend it to your colleagues, as I always say. Subscribe if you want to. Most importantly, follow through and look at parts 7 and 8 of Dr. Manny's Learn Shop's Pharmacology for Nurses. Bye for now. Stay safe.